I'm Dr. Estela Melman. I'm a professor of anesthesia, pediatric anesthesia at the American British Cowdery Medical Center, where I teach and I practice. Also, I work at the Los Angeles institution where I do the same. I'm also the president of the Mexican Board of Certification in Anesthesia. I decided to become a doctor when I was 12 years old. I had acute rheumatic fever and had to stay in bed for 3 months. My pediatrician, Dr. Morris Hoffs, was a very kind and imposing figure to me, and that really inclined me to follow his steps and become a doctor. I went to medical school where I met my husband. After graduating, I came to the United States of America to do my rotatory internship, which was required at that time. That was in the early 60s, and I went to Sinai Hospital where I did my rotation. And when I was rotating through through surgery and holding retractors without anyone being interested in teaching me anything, I used to lean back and listen to Dr. Eli Brown discussing the case with the residents, talking about pharmacology, physiology, and what applied to that particular patient. So that's what made me decide to go into anesthesia. I completed my residency in anesthesia with Dr. Eli Brown. He wanted me to go further and to apply to the University of Pennsylvania. And I went for an interview with Dr. Robert D. Trips, who accepted me become a fellow and in research. When I was doing research under Dr. Trips and with a team that did research on cerebral circulation, I asked Dr. Trips if I could rotate through the Children's Hospital because I was interested in going back to Mexico and becoming a pediatric anesthesiologist. I had already rotated to the Children's of Michigan, and I decided then that I wanted to be a pediatric anesthesiologist. Dr. Trips spoke to Dr. Leonard Bachman, and he accepted me to go and do pediatric anesthesia at the Children's Hospital. After I completed my training in the United States, I came directly to the Children's Hospital in Mexico City. I remember how difficult conditions were when I started. We used to comment that we would go by a color guide instead of having an oximeter. We would say the patient is less blue or less red or more pinkish. When I came to the Children's Hospital, we didn't have ventilators. The technician would sit and ventilate manually the patient. So that impressed me very much. One day in the cardiovascular section of the hospital, I was looking in a closet and I found a box which was not opened, and I opened it on my own and I found a Mark V ventilator. Nobody knew what to do with it. It had been donated to the cardiovascular surgery department, but they didn't know what that was for. I took it out and I started, I told them I'm going to start using it. Everybody was surprised, but we had a baby and I started to ventilate this particular patient. Sometime after, I went to company and I asked them, I was very friendly with the owner, and I told him to lend me one of his ventilators, and I went for the director of the hospital. I took him to my department and I showed him what I was doing with the two machines, with the two ventilators. So I convinced him and to substitute the negative pressure ventilators, which were a remnant of the polio epidemics they had 10 years before, and to substitute them for positive pressure ventilators. And I created the Department of Respiratory Therapy, which served the entire hospital. That was one of the things I was very proud of doing. I also started the craniofacial surgery, and I worked with one of the leading people in the world in craniofacial surgery, Dr. Ortiz Monasterio, who was a very good friend of the head of the department at CHOP, with Dr. Linton Whitaker, and we had very good results. I started also the profound hypothermia for for congenital cardiac defects, for congenital cardiovascular surgery, deep hypothermia. Shortly after Barrett Boys in New Zealand came out with this technique. Besides improving conditions at the hospital and teaching residents, we did research. I started to work on regional anesthesia in children. We worked in cadavers to determine the doses needed of local anesthetics to reach different metamera for different kinds of surgical procedures. And then we applied this to the patients, with obviously with consent from the parents. And I published in 1975 one of the first papers with our data. It was published in Anesthesia and Analgesia. And I got a very harsh comment at that time from the chief of the Department of Anesthesia in Birmingham, Alabama, who wrote that regional anesthesia would never be accepted in the United States or in any in any of the countries, developed countries. Probably it would be accepted in underdeveloped countries. In spite of that, I got letters from many people telling me to keep on working, because that was an irrational comment. After fighting conditions in Mexico and with the leadership I had learned from my mentors, Drs. Eli Brown, Dr. Grips, Dr. Eckenhoff, and fighting hostilities initially because of human conditions. I became later on the chief of the department and at the Children's Hospital in Mexico City. While I was the director of the Department of Anesthesia, I initiated the fellowship in pediatric anesthesia, and I had people come from all over South America, Central America, and I trained several generations of pediatric anesthesiologists.